In thinking about this, we're hearing a lot about allergic asthma, we're hearing a lot about eosinophilic asthma. Is there a difference? Is it the same? What's the overlap? What is the difference?
There's quite a bit of overlap. Not all eosinophilic asthma are allergic asthma. Um, Not all allergic asthma have high blood eosinophils, although many of them do. So I think in real life, just looking at eosinophils does not help you differentiate. You need to do more homework.
Yeah.
But it may be a marker of disease activity, and as the eosinophil counts go up, the incidence of exacerbation goes up too.
Right. As you see more inflammation, we see more exacerbations. With that would be sort of, I think, something that we all can agree on. And I think, unfortunately, because although we are dealing with a disease of the lungs and we don't have the ability to directly sample the lungs, right? We can't biopsy all of our patients with asthma with the prevalence of this disease as it is. And so we have to think about, okay, how do we start to think about this? And I think we'll get into a little bit more of that as we talk more about the biomarkers. But sort of thinking about that and moving forward, Brad, I'm going to pose a question to you and take a big step back. How do we diagnose asthma? How do we think about this disease, given this complexity of inflammation? And we heard a little bit about from Aiden about, what is the disease, what is happening? So then how do we diagnose it?
It's tough sometimes. It's sort of like love. You know it when you see it, but you can't really explain it. One of our mentors, Saul Permit, came up with that. But the point is that, especially in Sean Aaron's paper published in JAMA and the follow-up in the Blue Journal, that as many as 25% of patients treated both in primary care and specialist practice were undiagnosed with asthma when they were sent through a rigorous protocol that included bronchodilator reversibility, the presence or absence of airflow imitation, and a positive or negative methylcholine test. And that Canadian study showed us that some patients, as much as 25% of patients who are treated with asthma drugs, really don't have an asthma diagnosis, their primary diagnosis, and just gives us a little cause for concern and introspection, no matter where we sit in the cascade of asthma doctors about making sure that we have the right diagnosis.
So there's both over and under diagnosis, but how do we nail it down?
So that's actually a very important issue you're bringing up, because we see this all the time. Patients refer to us with uncontrolled or severe asthma on tons of medication, and we go really to square one. Do they have asthma? And actually, some of these patients may have mimickers of asthma. I can give you examples in my practice. Just the other day, I had a patient referred with severe asthma. It turned out that she had actually glottic stenosis or subglottic stenosis. She's been previously intubated and she had fixed upper airway obstruction. She certainly had the inspiratory sound on exam, and CT scan shows. So one has to go back to square one. Is this asthma? Spirometry definitely is important to diagnose asthma. Many of my COPD patients are labeled asthma. While both have airway obstruction, their response to therapy is different. And so really the very first thing to know when we deal with an asthmatic who's very difficult to control is this asthma after all.
The important thing is, even in ER study at your institution, that Ben Taub published many years ago, you've got to start with the upper airway and look all the way down to the alveolar airspace to really decide, is asthma the diagnosis? Is it interstitial lung disease? Is it other mimickers, bronchiectasis, smoking-related asthma?
At the same time, we also underdiagnose it. Many patients are referred to us with cough. We don't think about asthma. We start looking at other causes. And actually, it should be, the triad of symptoms, the classic ones we learned about in medical school, not always are there. Cough, shortness of breath, wheeze. Sure, if they're there, very high likelihood.
Right.
Spirometry is important. And in those patients with normal spirometry, even a bronchial challenge should be done.
Right.
Those usually detect mild asthma.
And in children, sometimes we have to, in fact, do a therapeutic trial of medication to make a diagnosis if they're too young to do.
Because you can't do spirometry.
Right. Yeah, I mean, I think getting back to it, we had sort of heard a little bit about the pattern of symptoms, right? And so you sort of saw someone who had symptoms that mimicked asthma in a way, but I think, getting that first medical history is great and wonderful. But as you said, not all of our patients present with cough, wheeze, shortness of breath that's worsened with activity, worsened at night. and that response to bronchodilators, which can make it a challenge. But we do get that medical history. And then we use adjunct tests in our physical exam. And you had mentioned things like chest CT and lung function. Brad, your thoughts on lung function testing? How often is it helpful, not helpful?
I think lung function testing is extremely helpful, both as it relates to airflow limitation, as it relates to bronchodilator responsiveness, as it relates to airway constriction with the cholinergic agonists such as methacholine or histamine or whatever you're going to use as a marker of airway hyperreactivity. And of course, exhaled nitric oxide as we look as that as a marker, a surrogate of eosinophilic airway inflammation.
Yeah. Aidan, do you want to sort of build upon that?
Absolutely. I mean, we used to think that the process of airway inflammation would lead to what Brad was describing, increased bronchial reactivity, increased smooth muscle spasm due to stimuli such as methacholine. And as that went untreated, then you would get what we call remodeling. These days, we tend to think these things maybe go separately from each other. You can be very reactive without having a lot of inflammation. You can have a lot of inflammation without having much reactivity, and you have children who have significant remodeling even early on, long before decades of untreated inflammation.
I mean, Andy Bush has shown that at the Brompton, that significant airway inflammation can occur with the paucity of symptoms.
Yeah.
So there's that, and then as Nick said, there are these masqueraders of asthma. So while yes, it's history and it's physical and it's lung function, you need to be fairly circumspect about it.
Yeah, and I think there can be sort of different time courses for these different sort of pathways to be involved, right? And you may have inflammation at one time that may lead to that airway hyperresponsiveness.
Right.
Inflammation can disappear, the responsiveness sort of in the
Right.
airway reactivity remains, which can make it a challenge for us, right? And so I think what I sort of have done in my practice is I say, look, let's look at all of these tools and let's look at them over a long period of time, because we can be wrong. And you have to always ask yourself the question, was I wrong about the diagnosis? Was I right? And constantly reassess, which I think is consistent with what the guidelines say.
And what is over all of this is the fact that patients don't take their medicine.
Absolutely.
And as we try to look at patients that are referred to us who aren't doing so well, is the main reason they're not taking their medicine. That's at least half the time.
I have a hard time believing that your patients don't do everything you tell them to do.
Well, they all do, but I'm just talking about your patients now, not mine.
Exactly.